Good morning and afternoon. My name is Tracy Cook, and I'm with Sachs Healthcare Communications. I'd like to show our audience today how to send your questions, which our speaker will answer as many as possible at the end of the webinar. Please type your questions into the questions box. Our moderator today is Christina Davis. Christina is currently an adjunct professor at University of United States in San Diego, California, and Aspen University in Denver, Colorado. Christina has an extensive background in GI digestive disorders in both the treatment and diagnosis of GI disorders. Her background includes clinical research with the NIH and FDA on infection-related topics. Christina, welcome.
Hi, Tracy. Good morning. Thank you for that very kind introduction. The title of today's webinar is Barrett's Esophagus, Changing Algorithms in Patient Management. Speaking today on this very important topic is a leading expert in the field, Dr. Nicholas Shaheen. Dr. Shaheen performs extensive clinical and translational research in diseases of the esophagus, with a special emphasis on precancerous and cancerous lesions. He is interested in developing improved methods of detecting people who have these conditions before they present with symptoms. He is chief of gastroenterology at UNC and has authored more than 300 papers on these topics. The speaker disclosed the following financial relationships: Medtronic, Pentax, Steris, CDX Medical, Lucid, Cook Medical, Cernostics, and Boston Scientific. The opinions expressed are the personal opinions of the speaker and do not reflect the opinions or views of the sponsor, which is Medtronic or Sachs Healthcare Communications. This has been approved for 1 AMA category credit for physicians. A link to obtain your certificate will be available at the end of the webinar. Below is the accreditation statement. And this has been also approved for 1 contact hour for nurses. A link to obtain your certificate will be available at the end of the webinar. The accreditation statement is below, and support for this activity has been provided by Medtronic. And I would like to turn it over to Dr. Shaheen now.
Thank you, Christina. What a pleasure it is to be here today with you to talk about this topic, which is something I'm really passionate about, which is Barrett's esophagus, changing algorithms in patient monitoring. I'm going to start with a few learning objectives. The learning objectives here are to describe new data in chemoprevention of esophageal neoplasia, to discuss the utility of non-endoscopic methods for screening for Barrett's, and to recognize appropriate patients for endoscopic therapy of Barrett's esophagus. So let's start with a case. This is a patient of mine, 73-year-old man. He's a retired Wilmington police officer, spends his time out on his boat now. Wilmington, North Carolina is out on the coast. And he comes in because he's got food sticking in the middle of his chest with most meals. His symptoms have been progressive and now associated with a 23-pound weight loss. He's had reflux symptoms for over 20 years, and he's medicated daily with a proton pump inhibitor for 15 years. Overall, he's otherwise in good health except for being a little bit overweight. He brings this barium swallow with him, and if you're used to seeing these, you can see that what we want to see on a barium swallow is the nice, normal, smooth contour of the esophagus, which you see up here. Instead, what we see in his distal esophagus is this shaggy exophytic mass, and you can see that the barium is trickling through there very irregularly, suggesting that he's got a large mass down here. And sure enough, when we perform endoscopy, this is what we find. You're looking now down the esophagus, that same area I was showing you on the radiograph. And now what you see is sitting in this field of Barrett's esophagus to the right, a big cancer here on the left. And it's got a big central ulceration with it. This looks to be quite an advanced cancer, which is obviously blocking off part of his esophagus and leading to his dysphagia. So at that point, unfortunately, he's staged with advanced or stage 4 esophageal adenocarcinoma. He receives chemotherapy and radiation therapy, but really doesn't have a terrific response to this, has ongoing weight loss. He sees me back in clinic and we talk about his prognosis. One thing he makes clear to me is he wants to make it to his granddaughter's wedding, which is that summer. This is in the spring. In order to improve his nutrition, we go back in and we place a stent to allow food to go through that narrowed spot. Unfortunately, this man died the week before the granddaughter's wedding. I'd like to say that this is an abnormal case of esophageal cancer in the United States. This is the normal case of esophageal cancer in the United States. Here I show you both the incidence of esophageal adenocarcinoma, the kind of cancer that arises from Barrett's that I just showed you pictures of, as opposed to esophageal squamous cell cancer. And you see it's quite interesting, the lines are diverging here. If you look from 2004 to 2015, you can see esophageal adenocarcinoma is actually going up, while at the same time squamous cell cancer is going down. Now I show you the incidence curve again, this time dating back to 75, and I match it with the mortality curve over the same period of time. And although it looks like these two lines are spreading a little bit, suffice it to say that this is a very lethal cancer. If you get esophageal adenocarcinoma, there's an 80% chance that you'll be dead within 5 years. And it's not going to change anytime soon. These are trends in incidence on the top here and mortality on the bottom here for males with esophageal adenocarcinoma looking out through 2025 and 2030. And these are projections from multiple different sites that have done these analyses. In every single case, what you can see is that we expect both the incidence of this cancer and the mortality of this cancer to continue to rise at least for the next 10 or so years. This is a really interesting graphic, and what this shows you is for every year from 1975 on, for the cancers that were diagnosed, how many of them, what percentage were diagnosed in a localized or early stage, which had regional spread, meaning that it was starting to spread to the other organs around the esophagus, which ones had distant spread, which means that they had metastases, say to bone, lung, or other places, and which were unstaged. Now, if you were doing good screening and surveillance for cancer, what you would expect to see is that this blue portion, the localized stage, should go up with time. That's not what you see with esophageal cancer. What you see instead is that the proportion that's diagnosed localized has stayed roughly the same from 1975 to present. In fact, the only notable change you have is that we're staging a few more of the ones that we used to unstage as distant disease. So this isn't a terrific story for us in terms of preventing cancer. So I think it's fair to say, based on the numbers I've shown you, that we're losing the battle against esophageal adenocarcinoma. And in fact, when you look at how patients are presenting with this cancer, you find that the vast majority of them are presenting at a stage that is quite late. So here's one study, all of these studies look the same, asking what T stage the cancer presented in. And you can see over 90% of these cancers are presenting at T3 or T4, i.e. advanced stages of cancer. In these advanced stages, treatment options are few and prognosis is poor. So, as I mentioned before, Barrett's esophagus is the precursor condition to this cancer. And if the cancer is going up, then you would expect to see that the incidence of Barrett's esophagus is going up as well. And that indeed is the case. And you can see in these pictures here a couple of classic pictures of Barrett's esophagus. In both cases, the whitish tissue here is normal squamous mucosa, similar to what you have in the palm of your hands. The pinker stuff is the neoplastic, the pre-neoplastic tissue, the Barrett's esophagus. And you can see it's radiating up from the bottom. The stomach would be down here in this case, and here in this case, up into the esophagus. We care about Barrett's because on relatively rare occasion, Barrett's will progress through these stages to cancer. So what you see here in the upper left is a classic picture of non-dysplastic Barrett's esophagus. You can see the normal crypts and glands of the Barrett's esophagus. If you look at the nuclei here, they're all very nicely basally oriented, okay? And then if you have the first step toward cancer, you get what's called low-grade dysplasia. You can see the nuclei here are bigger. Glands are still present, perhaps a little less ordered. Now you move on to high grade. These cells look very pleomorphic. These nuclei are very large, starting to get disruption of glandular structures. And then finally on to adenocarcinoma, and that's this figure here, and you can see just sheets of very anaplastic looking cells. Now, I presented this to you like it's an inexorable progression, but in truth, the majority of patients, the vast majority of patients with Barrett's will not go beyond this stage or this stage, i.e., very few, less than 5% of the total, will move on to adenocarcinoma of the esophagus. I mentioned before that since this cancer is going up, our incidence of Barrett's should be going up as well. And indeed, when you look at the data, that's what you find. This is an interesting study of almost 60,000 endoscopies in a single center in Spain, asking the question, what is the incidence of Barrett's esophagus in these endoscopies? And what you can see here is this dark line stands for long segment Barrett's esophagus, which is Barrett's esophagus of 3 or more centimeters. It's going up. You can really see that short segment Barrett's esophagus, i.e. Barrett's of less than 3 centimeters, has gone up dramatically. Now, some of this is probably detection bias. We've gotten better equipment, but certainly this part, at least, I think is a very believable increase in the amount of Barrett's that we're seeing. So the logical question, of course, is why is this going up? Why is this happening? And we don't know for sure, but we postulate that the increasing cancer incidence could be secondary to the epidemic of obesity. And if you want to talk about the public health challenge of our lifetime, putting aside COVID and everything else we've talked about, in terms of chronic threats to public health, it is the epidemic of obesity. And sure enough, when you look at obesity as a risk factor for this cancer, it's really quite striking. If you're of low body weight, you have a relatively low risk of this cancer. If you're even of average body weight, your risk is about 3 times that of a low body weight person of getting this cancer. If you're overweight, it's about 8 times. And if you're obese, it's 16.3 times the chance of getting this cancer compared to a low weight individual. So it's really quite striking. So what do we do to try to prevent all of this? Well, endoscopists try to lower the risk of cancer death in those with chronic reflux by performing screening and surveillance endoscopy. And just to make sure that we understand the difference between those two, we scope people with chronic heartburn. So if you come in and you say, gosh, I've got heartburn, we're going to do what's called the screening exam on you. And during that screening exam, we're not only looking for cancer, we're looking for Barrett's, the precancerous condition. If you do have the Barrett's, we periodically rescope you for surveillance examinations, and those are termed surveillance. So that's what screening and surveillance is. And here are our current guidelines for who deserves that first exam. So if you're talking to PCPs or if you are a PCP, this is what you need to be thinking about. We look at patients with chronic reflux symptoms, most commonly heartburn, but could also be things like regurgitation, water brash, and what have you, and at least a couple other risk factors. And here are the other things that put you at risk of Barrett's. Being a man, being greater than 50 years of age, having central obesity, i.e. having weight around your midsection, Caucasian, smoking, first-degree relatives with Barrett's. And you can see that all of these various societies use some combination of these risk factors to decide who should be getting scoped initially. One problem with what we're doing, though, is that those reflux symptoms, heartburn, both its presence and its frequency are poor predictors of the presence of Barrett's. In other words, many people who have Barrett's don't have a lot of heartburn, and some people with lots of heartburn don't have Barrett's. So when you look at the data, what you find is that in almost every study of esophageal adenocarcinoma, if you ask the patients, did you have heartburn before you got your cancer? In about 40% of those cases, they will report no heartburn symptoms. And we term these non-GERD cancers. And if we use heartburn as our screening bar that you have to jump over before we decide we're going to do endoscopy on you, we're going to lose 40% of the findable cancers from our endoscopy pool. So this is one of the most important slides I'm going to show you, and this is why we're not having a lot of success in bending those curves that I showed you at the beginning. We're not getting to the people we need to get to. If you look at patients who have developed cancer and you ask them, did you know you had Barrett's before you got the cancer? 95% of the time in study after study, and here's a couple of them, but they're all the same, say, I didn't know I had Barrett's. It's going to be hard to make changes in those curves if the precancerous condition it goes undiagnosed in 95% of the people that are getting the cancer. We can only improve care in this black wedge if we're going to concentrate only on the patients with known Barrett's. So clearly, to make things better, we've got to find a better way of diagnosing this 95%. So when you apply what I've just told you on a national basis on the US, this is what you get. This is a really cool model that Tom Vaughn and Rebecca Fitzgerald did a few years ago, asking the question, what would we really find if we actually applied all of our guidelines to every person in the US? And they started with the 150 million people in the US population who are greater than 40 years of age. Now, about 80% of people have no GERD symptoms, so we're not going to find any of those cancers that occur in that group, and 20% do have GERD. Think about that for a second. 20%, 1 in 5 Americans have GERD. It's an incredibly common problem. Now, I've already told you that 40% of the cancers are going to happen in the patients who don't have GERD, so we've lost those. If we're concentrating on using GERD patients as the patients we're trying to prevent the cancer in, we've already lost 40%. Now, as you go on, amongst the 20% of GERD patients, 9 out of every 10 of those never undergo endoscopy. So you can't make a Barrett's diagnosis with no endoscopy because, as I've shown you, you need that endoscopic image to find the Barrett's. So we're talking about 10% undergoing endoscopy, or 3 million of these 30 million. Now, we know in those patients, we are going to find the majority of the Barrett's. We also know that we cut this pie so fine now, we've lost another 52% of the cancers in patients who never undergo endoscopy. So you can see what's happened here. Between the patients that never undergo endoscopy but have GERD and the patients without GERD, we've lost 92% of the cancers. And we're only finding 7% of the cancers that are going to happen in the US every year. So out of these 10,000 cancers, if we do what we want to do or what we've been suggested to do, we're going to find 7% of them. So this leads to unavoidable conclusion that we've got to find a better way to detect at-risk patients. So how are we going to do that? How can we screen patients who have heartburn? They come to their PCP's office, they say, I've got heartburn for Barrett's. Well, I'll show you a couple of things that are out there now, which I find very compelling. The first one that I'll show you is what's called the Cytosponge. What this is it's low tech. This is just a sponge that's inside a gelatin capsule. You swallow it. The gelatin capsule dissolves in the patient's stomach, and it sits in there for about 5 minutes to let it completely expand. And then all you do is you pull this string back. And I've done this to myself, actually. It's not very uncomfortable, except when it goes through your lower esophageal sphincter. Then you feel it a little bit. As the sponge comes back, it picks up cells in the esophagus, which then can be shaken off, spun down, and stained for a marker for Barrett's esophagus. And these are what the data look like. This thing's been around for about 10 years now. This was one of the early studies of 500 patients in a general medicine population. What they found is for Barrett's of greater than 1 centimeter, sensitivity was 73, specificity was 94%. And if you had more Barrett's, and as you know, the more Barrett's you have, the more cancer risk you have, the sensitivity goes up. So for Barrett's of 2 centimeters or more, about this much, you're talking about a sensitivity of 90% and a specificity of 94%. So pretty promising numbers. And they've just recently done a very large, pragmatic, randomized controlled trial of this in England and found that they could improve the detection of Barrett's by having patients undergo the testing. In fact, the people that were randomized to that testing, about 10 times as many were found to have Barrett's compared to standard of care. So the next one I'll show you is also a very interesting one. It has the same basic idea, but it's a little bit higher tech. This is a little balloon with little spiky things on it here. We'll show you a little close up. You see that? And those little spiky things, they collect cells. The patient's going to swallow that. You'll see it here. This person is very Not everybody does this as well as this guy does it. And then we blow up that balloon, and then we pull it back, and the little spiky things collect a cell sample. We cut off the end of it, and we put it in a cup, and we look for Barrett's markers in that. And we've just recently done a study of that as well that was published in Science Translational Medicine. And if you're not used to looking at these areas under the curve, this test was highly sensitive and specific for finding Barrett's esophagus. And each of these curves represents a different marker that we use to look for Barrett's and a different kinds of cancer, Barrett's and cancer as well. And what you can see is that all the sensitivities and specificities are quite high on this test. I don't want to go through this in detail, but I will point out the sensitivity and specificity of 94 and 92% for either one of these two markers. And these are the two markers that we're using to find the cases. The last one I'll mention to you, which is kind of a pie in the sky thing, and we'll see if this pans out, but it's really interesting. There's only been one publication on it to date, is what's called the electronic nose. And what this does is you breathe in and out through this machine, and it collects the organic compounds that are in your breath. It then analyzes these compounds via a neural network and remarkably can tell whether or not the patient has Barrett's. And here's the data from that study: 82% sensitivity, 80% specificity, with a pretty good looking ROC under the area under the curve, which is 0.79. So what should you be doing with these patients if you find them? Right now, if you find Barrett's, but there's no precancerous change in it, you're looking at repeat endoscopy. If it's very short segment, in 5 years. If it's longer segment, greater than 3 centimeters, in 3 years. If you're indefinite for dysplasia, so they say the pathologist says you have Barrett's and the biopsies show that you're indefinite, you have to have a second pathologist look at it because there's a lot of variability in these reads. Then you double up their acid suppressive medicine and repeat that test in 6 months to see if they're still indefinite. A lot of times that'll go away. Finally, for low grade, high grade, or early cancer, you confirm again by a second pathologist. And then we usually perform ablation. Although if they have low grade dysplasia, sometimes we do endoscopic surveillance like these folks over here. So this is a really interesting question. One thing that comes up all the time is, what medication should I be giving my patients with Barrett's? Well, we do suggest that everybody with Barrett's esophagus get at least once daily proton pump inhibitor. There's now substantial data to suggest that those patients will be less likely to progress to dysplasia if they're getting acid suppression every day. More interesting is how much they need and whether or not they should have aspirin with it. We've known for years that aspirin prevents many cancers, so should we be giving these patients aspirin? The answer to that question, it comes from the ASPECT trial. This is a study that was published a couple years ago, a very large study of patients primarily in the UK who were randomized to one of 4 arms. Either low dose PPI and aspirin, low dose PPI and no aspirin, high dose PPI with aspirin, or high dose PPI with no aspirin. So it was a factorial design. There were a total of 4 groups. There were 2,557 randomized patients who were followed for almost a 9-year average, and they were followed till either they died, they developed cancer, or they developed high-grade dysplasia. And what they found was giving a lot of PPI seemed to protect more than giving a low dose of PPI. However, aspirin was not superior to no aspirin. So the bottom line is, I don't routinely use aspirin in my patients with Barrett's unless they have another reason for me to give it to, like for instance, cardio protection. I tend to give higher dose PPI to these patients, but not as high a dose as used in this trial. Patients tend to be worried about doses this high, but we will go with, say, 20 BID of omeprazole or BID dosing of PPI for a lot of patients. In fact, in about a third of patients with Barrett's esophagus, once daily dosing still has an abnormal pH study associated with it. So you end up needing the higher doses for symptoms or acid control in many patients anyway. I'm going to say a couple words now about endoscopic eradication therapy for dysplastic Barrett's esophagus. So what we're speaking to now is I'm watching a patient, I've done my job, I found that they have Barrett's on their screening exam, I have them in surveillance, and now they've developed dysplasia or precancerous change. What do we do for those folks? Well, the first thing we do is take out any nodularity. If Barrett's is going to turn to cancer, the first thing it does is get nodular. And here's a nice set of pictures from one of Ollie Pesch's papers looking at a nodular area of Barrett's in both narrow band imaging and white light. Now they've got a bander on there. They've sucked that area of nodularity up and they put a rubber band around it. And now then they cut off the area, they've excised that area of the nodularity and leave just submucosa, which is what you're looking at there. So what are our choices now for getting rid of the Barrett's esophagus? Well, those of you that have been around for a while may remember this. This is photodynamic therapy. That's a laser in there. We used to drop this into the patient's esophagus, place the laser across the area of the Barrett's, but we don't do that anymore. This is argon plasma coagulation. We use that rarely. It's good for small areas of Barrett's, but not large areas. This is the workhorse now. This is radiofrequency ablation, which is used quite often. This is spray cryotherapy, where we're spraying liquid nitrogen into an area of Barrett's. And this is a balloon-based cryotherapy, where we're spraying a cryogen on the inside of a balloon to kill the Barrett's, which is sitting on the outside. So to give you some idea of what these look like, this is the spray liquid nitrogen cryo. And you can see that I'm scoping this patient and I'm spraying the liquid nitrogen on this area of Barrett's here, and I'm making it as hard as an ice cube. And it's really remarkable that the human body can tolerate this. But what happens is that this kills the Barrett's and allows healthy stuff to grow back in. You see this decompression tube, that's sucking out the gaseous nitrogen after the liquid boils off, because liquid nitrogen expands quite a bit. So you can see what a hard freeze I'm putting this area of Barrett's into with this treatment. Then I'm going to let that area thaw a bit. You can see it's thawing now. I'm going to let that blood come back in there, generate free oxygen radicals to kill the Barrett's off. And then we're going to give a second, as soon as we get it defrosted, we're going to give a second spray here to give a second hard freeze, and that's the way this is done. And we'll choose multiple areas throughout the Barrett's to get rid of the Barrett's. The last one I showed you, which was that balloon-based cryotherapy, is the newest kid on the block. The first generation of it looked like this, and this is the second generation here. And what you see in both cases is a balloon that goes down through the scope, that's controlled by the floor pedals here, but essentially we're blowing cryogen inside this balloon. And this has the advantage of not having the cryogen just blown into the lumen. This is what this looks like. You can see the balloon here. We're positioning the balloon in the area that we're going to treat. Now we're putting a little cryogen in the balloon, and I'm looking through the balloon to target Barrett's. And you can see these islands of Barrett's here and here and here. Now, if you look very closely, you can see a little hole at the top here, and you can see a little puff of nitrous oxide. And I like that position. I want to kill that island of Barrett's there. So now I'm going to step on the pedal, and I'm going to lay on it for 10 seconds. And it's going to generate this big patch of ice that you can see spreading. It's the same idea as before. We're killing the tissue. Now you'll see the balloon drop, and you'll see what this thing looks like when you're not looking at it through the balloon. There it is. And you can see that's a substantial patch of ice that we've created there, and that's going to kill the Barrett's. Now you can also see that I've got a bunch of Barrett's over here I haven't treated yet. So I'm going to rotate that balloon, and I'm going to treat that area. So how well does that work? This was a study that we published last year in the American Journal of Gastroenterology. And this is what it looks like. So here's a patient when they just got started in their treatment. This is an 11-center US trial, and it's called the Coldplay 3 trial. And in 120 patients, we were able to get a complete response for dysplasia, meaning we were able to get rid of all the dysplasia in 76% of patients. And we're able to get a complete response for intestinal metaplasia, meaning we got rid of all the Barrett's. This is a harder thing to do in 72% of patients. Per protocol, these numbers were quite higher. We had some patients drop out in the study, so the numbers even look a lot better if you finished all of the treatments that you were assigned. Only one of these 120 patients went on to get cancer, and the safety data looked quite good. There were 3 serious events, which is 2.5% of the 120 patients. When we asked them what their pain was on the day after they got the treatment, they rated on a 0 to 10 scale. They rated 2 out of 10, and only 8% of patients ended up needing narcotics. And this is what those pictures look like. So that is a very nice treatment that we're working with now. So who shouldn't get these treatments? This is a really important slide. Any lesions that are too deep, if it goes too far into the wall of the esophagus, into the submucosal layer, you should at least be considering esophagectomy. If it's very superficial in the submucosal layer, it can be managed endoscopically. If the lesion is too aggressive, if it's poorly differentiated cancer, if there's lymphovascular invasion, they should not get endoscopic therapy. And if the lesion is not amenable to endoscopic therapy, if it's too large, if it's too big a lesion, or if you can't raise it up in the air to be able to cut it out, then those patients should be considered for surgery as well. But most of these patients we're able to handle endoscopically. So let's go on to some conclusions. The epidemiology of both Barrett's and esophageal adenocarcinoma is unfavorable, as I showed you at the beginning. Current screening and surveillance practices in Barrett's are limited by poor risk stratification. We just don't know which patients are going to go on to get Barrett's or get cancer. And remember that slide I showed you about how we're losing all these patients in our current screening and surveillance practices, and how many of them were not able to find their cancers because we've essentially not scoped them in time. Non-endoscopic screening methods hold promise for allowing a more expedient diagnosis of Barrett's. So remember that sponge and those balloons that I showed you. Now those can be done in primary care. Those don't need to be done in the GI's office. And what I see in the future is that we're going to be mounting these screening programs in primary care offices, and we're only going to see the patients once they've shown themselves to be positive by one of those less invasive methods. In this way, you can make screening much more cost effective. Both those things I showed you are much cheaper than an upper endoscopy with sedation and biopsies. So this might be a good way to get at lots of people and get them involved in screening. The randomized data suggests better outcomes with high dose PPI than low. Okay, and remember I told you about the ASPECT trial that kind of showed that the patients on higher dose PPI seem to have less chance of going on to get cancer than those on the 20 milligrams once a day of omeprazole. Remember also that the patients who got aspirin in that trial didn't seem to do much better than the patients who got no aspirin, and for that reason I don't think routinely giving these patients aspirin unless they have another reason that they need it is appropriate. In patients with T1A adenocarcinoma, meaning very superficial adenocarcinoma, high-grade dysplasia, and at least some of the patients with low-grade dysplasia, we're going to do that endoscopic therapy. And I've shown you several here that are being developed now. I think all of the ones that I've shown you, radiofrequency ablation, spray cryotherapy, balloon-based cryotherapy, are good at getting rid of Barrett's. We don't have much head-to-head competition, so one question that's natural to ask when we have multiple modalities is, well, gosh, which one's best and when should we use what? It's a little hard to answer now, that question, but I think it's going to become more obvious as we start doing more head-to-head studies, and those are just starting to be done now. So I'd like to thank you all for your attention for this. I hope that I told you at least a few things you didn't know yet, and I'm looking forward to our discussion. I'll turn the mic back to Christina, who is going to moderate our discussion and pull up the questions that you all have sent in, as well as anything I've confused her on, which is probably substantial. So Christina, back to you.
Thank you for that wonderful presentation. So I would like to go over how to obtain your continuing education credits. So again, this is approved for 1 contact hour for physicians and nurses. So in order to obtain your CE credits, you'll go to www.saxtesting.com/INIT. You'll need to register at the site, complete the evaluation, and then once you do that, you'll be able to print your certificate. And then the archive version of this will be available, or the on-demand version will be available at www.initiatives-patientsafety.org. An email will be sent out to everyone when it's available, and the on-demand version will also be accredited for physicians and nurses. All right, so let's get into the nitty-gritty of questions. Let's see what came in. Okay, is RFA better than cryo?
Yeah, terrific question. The answer is that I can't answer that question because we don't have head-to-head comparisons. This is what I can tell you, and this is how I think about it. I think about these tools for ablation more like you might think about clubs in a golf bag. By that, I mean these are all different tools that we can use to get rid of Barrett's. And which one we use kind of depends on what the Barrett's looks like and other patient factors. So to give you an example, sometimes patients who have these conditions have a big hiatal hernia, and when you go to take a radiofrequency ablation paddle, one of the shortcomings with radiofrequency ablation is you've got to be able to push that catheter really hard and well against the tissue to get a good result. If you're not really getting good pressure on the tissue with the catheter, the tissue won't burn and you won't get good reversion to squamous epithelium. If I've got a big hiatal hernia and I push against the tissue and it just moves away from me, or I can't even get a good hard press of my catheter on that tissue, I'm going to go with cryotherapy or argon plasma coagulation, one of the two, something that I don't need to push on, something I can spray on. So situations like that. It's also quite common if I'm not getting the degree of reversion that I want. If I've treated someone, say 2 or 3 times, they've still got more than 50% of their Barrett's left, I might switch modalities because one may be more susceptible to a certain kind of ablation than others. So I tend to use them interchangeably and in combination. I think with time, we'll probably have better head-to-head comparisons, and when we do, then I'll be able to better answer that question about what you should start with. One thing I will tell you now is that the only modality for which we have level 1 evidence of prevention of cancer incidence is radiofrequency ablation. So there are 2 studies now that show that patients who get radiofrequency ablation are less likely to go on to progression of their disease than those who don't get those treatments, and those are both radiofrequency studies.
Wonderful, thank you. And this question sort of leads on what we just talked about, but at what point is radiofrequency ablation appropriate or recommended to patients with GERD/Barrett's esophagus?
Yeah, so I try to get at that a little bit in the talk. How you think about who you should treat is primarily has to do with 2 issues. One is how serious is their Barrett's, and number 2 is are there other patient factors that affect their life expectancy? So let's handle those one at a time. The first one, so how far progressed is their Barrett's? If you have Barrett's with no dysplasia, no precancerous change, all the societies recommend that such a patient should not undergo ablation. And you say, well, you've just told me that ablation is highly effective. Why don't we just ablate everybody and be done with it? And the answer is that 95% of those people will never go on to get cancer. So we would be treating 19 patients for every one who benefited. And if it were completely benign, you might be willing to do that. But unfortunately, ablation has its own complications associated with it. So what I tell my patients with non-dysplastic Barrett's is, I've got a better chance of hurting you than helping you by ablating you at this point. Instead, we should keep you under surveillance, and only if you're in that smaller group that progresses should we consider ablation. Now, for the low-grade group, we do have some evidence that suggests that ablation may be better than no ablation in terms of halting progression. It's a single study. It's out of the Netherlands. It needs to be confirmed with a larger study that also uses patient-reported outcomes. But for now, at least based on that study, we do offer patients who have progressed to low-grade dysplasia ablation. When you get the more serious forms of Barrett's, i.e. high-grade dysplasia and superficial cancer, then the answer has become clear. Those patients should all have ablation. And the reason is that their rates of progression are unacceptably high if we leave them alone. If you have high-grade dysplasia, your rate of progression to cancer in a single year may be as high as 20%. So, you know, in that situation, clearly those patients deserve ablation. The other factor that I mentioned was the patient's overall health. So in general, if someone looks like they have less than 2 years to live, they probably shouldn't be undergoing any Barrett's endoscopy to begin with. And if they do have Barrett's, unless they have actually cancer that we can treat, you know, thinking about ablation in such a patient doesn't make a whole bunch of sense because their life expectancy is so short. So you look at the patient factors, and if you're over 75 and you've got low-grade dysplasia, I often tell those patients, let's just keep an eye on you, let's not ablate you, because, and I don't say this out loud, but the likelihood of something else getting you before the ablation, I've never figured out how to say this in a way that doesn't sound terrible, but if I could figure out a way to say, you know, there's true that there's competing mortality for people. And if you've got COPD, and if you've had 3 heart attacks, and if you've had a stroke, and you come see me with low-grade dysplasia, well, some of that other stuff is almost certainly going to get you before your Barrett's gets you. And that's essentially why we don't ablate such a patient. But I haven't figured out a way to say it that doesn't sound like, oh, I think you're going to die of something else first. So if anyone has a good way of saying that, put it in the chat box, because I always kind of talk around it. So.
Well, thanks for that. And a question that you did cover, but more specific, why do the guidelines not really mention females in relation to Barrett?
Wow, terrific, terrific question. So, and that was very perceptive, whoever picked that up. The data I showed you and the guidelines both concentrate on men. And that sounds awfully sexist at first, but it turns out that over 80% of these cancers occur in men. Being male is such a risk factor, both for getting Barrett's and for getting this cancer if you have Barrett's, that we use male sex as one of the risk factors to whether or not you should get endoscopy looking for Barrett's. That's not to say that no women should ever be, if you've had GERD symptoms for 10 years and you're overweight and you smoke and some of those other risk factors I showed you, absolutely fine. We should be screening such a woman for Barrett's. But know that this is a far and away more likely a male than female cancer, far and away more likely a Caucasian than Black or Hispanic cancer, okay? Much lower in African American populations, much lower in Latina populations. So that's the epidemiology of disease, and we use that to help us pick out who we're going to do screening and surveillance for. Then, of course, the immediate question is, well, gosh, why is it so much more common in men than women? We know GERD is about roughly equal in men than women, right? So just about as many women have GERD as men as a proportion. So why are the men the ones that get all the cancer? And the answer is we don't know. It might have something to do with the way men get fat. When men get fat, they get shaped like apples. Most of their obesity is intra-abdominal obesity. Women are much likely to get glutofemoral obesity, meaning their thighs and their buttocks. It turns out that intra-abdominal obesity does 2 bad things for you. One, it makes you get a hiatal hernia because all that intra-abdominal pressure is pushing your stomach up into your chest. The second thing isn't as immediately obvious, and that is intra-abdominal fat is biologically a lot different from fat in your butt. Fat in your stomach makes more insulin and insulin-like growth factor than fat in your hips and your bottom. So what you see, interestingly, is if you have a lot of intra-abdominal fat, you're predisposed to cancers that have no mechanical association. Like women with intra-abdominal fat, more intra-abdominal fat, are more likely to get breast cancer. Well, you know, there's no mechanical explanation why that should be. They're more likely to get colon cancer. We think it has to do with these circulating hormones that people that have a lot of intra-abdominal fat have. And that's the way that men tend to carry obesity. They tend to be apples more than pears. So this may have something to do with it. But the short answer is we don't really know. I find this stuff to be interesting, which is why people don't want to hang out with me at parties. But you know, this idea that how you carry your fat matters probably has something.
Absolutely. Absolutely. Thank you for that awesome explanation. What is the pathophysiologic relationship between a hiatal hernia and GERD, and I guess in relation to Barrett's as well?
Yeah, that's a terrific question. So to review, a hiatal hernia is where the uppermost part of your stomach, your cardia, perhaps your hypophysis, has pushed through the hiatus, the opening of the diaphragm that allows the esophagus to go through, such that a portion of your chest is now above your diaphragm. The effect of that, the cumulative effect of that, is that it's a permissive factor to allow reflux. And the reason that happens is that this nice pinch valve you have when your esophagus is in the anatomically correct position, where your sphincter is actually in line with your diaphragm and reinforcing the diaphragm, that's a very good confirmation for keeping acid out of your chest. Once you displace those two, once the diaphragm is no longer in line with the sphincter, although the diaphragm helps a little bit and the sphincter still helps to keep acid out of your chest, you've now created a situation where that barrier is disrupted, and it's a permissive factor to allow reflux. And the bigger the hiatal hernia, the more permissive the factor is. And interestingly, the bigger the hiatal hernia, the more likely you are to get Barrett's as well. So it's pretty clear that hiatal hernia is a permissive factor for the development of Barrett's. And in fact, almost every patient you see, it's not 100%, nothing's 100%, but in almost every study, well over 80% and sometimes over 90% of patients with Barrett's have a hiatal hernia that we notice. Now you say, all right, well, does that mean everybody with Barrett's should get their hiatal hernia fixed? Should they all have surgery? Should that, because that might help things? And the answer is that after that, we think the cat's out of the bag. So don't do surgery just because somebody has Barrett's, okay? Those patients will have about the same risk of getting cancer if they're managed medically or surgically. So Barrett's, and this is an important thing for anybody listening that does primary care, Barrett's is not an indication for an anti-reflux surgery or repair of a hiatal hernia, okay? Even though we think the hiatal hernia probably helped cause the Barrett's, that's kind of like, you know, the cow's already out of the barn and then we'll go close the door. Or whatever analogy you want.
So that kind of leads me into another question. I'm sure this comes up often, but I think it's a good question. What is your favorite PPI to use? Do you prefer one over the other? I know you mentioned omeprazole, but are there any others you prefer? What are your thoughts on this?
So I prefer the one the patient can afford. Okay. Almost always nowadays, insurance companies are very cost conscious when it comes to PPIs, and almost always they will have a preferred PPI that's on their formulary that the patient can get at very low cost. Or for some insurers, they try to shift the cost of PPIs onto the patient entirely, and they say, we're not paying for any prescription PPI, you need to go buy over-the-counter PPI. Well, over-the-counter omeprazole, which is available in 20 milligram capsules by, I think, multiple manufacturers, is the same, it has the same efficacy as prescription omeprazole. Since I tend to use a fair bit of BID PPI, twice daily PPI for these patients, I'm happy with pretty much any PPI that the patient can get cheaply. Okay. If it's once a day, there are, as you know, head-to-head comparisons of the PPIs. What they show in general is that the PPIs, at least for healing erosive esophagitis, are all within 10% efficacy of each other. So there's not enormous differences. The newer PPIs, dexlansoprazole and esomeprazole, when compared to their parent compounds, lansoprazole and omeprazole, are somewhat more effective. Those are the purified enantiomers of those compounds. So if you go from, say, omeprazole to esomeprazole, you can expect to get somewhat better acid control. Similarly, if you go from lansoprazole to dexlansoprazole, you can get somewhat better acid control. But again, we're talking about small differences here. So to make a short story long, I want them to get what they can afford and what they'll take. The biggest problem people have is not picking the wrong one. It's getting the patients to take them. All right.
Take it correctly.
Yeah, well, they're taking it all. I mean, patients, you know, 50% of the prescriptions written in the United States are never filled. I think most doctors don't know that number. It's a pretty humbling number, you know, for providers to know that there's a 50-50. You put all this thought into this. You think you've done a great job working up this patient. You hand them 2 prescriptions. It's a 50-50 whether or not they're going to fill any of them. And if they do fill them, the likelihood they're going to be on them for chronic meds within 3 months is again goes down by a 50% ratio for things like PPIs. So understand what really happens when you write a prescription in the United States. So if you want your patients to take these medicines, you really got to harp on them. You got to check with them every time. Are you taking it? Don't believe them when they tell you they are taking it. Ask them again. Make sure that you really drive home that you can decrease their chance of progressing to cancer in their Barrett's if they take these medicines.
Got it. Okay, well, thank you for that. What recommendations would you give to a patient with a strong family history of esophageal adenocarcinoma and say they just have, you know, short segment Barrett's, but, you know, they're concerned? What would you say?
So let's put those folks in 2 buckets just for interest. Let's say they've got a strong family history and they have reflux and you scope them, but they have no Barrett's. That patient is relatively in the clear. What we know about Barrett's is if you have at least 5 years of reflux symptoms and you haven't developed Barrett's, the likelihood is you don't have the genetics to develop Barrett's. And in fact, when you scope a person like that down the road again, the likelihood they will have developed new Barrett's is very low. So low, in fact, that we recommend a single screening and that they don't need another endoscopy, even if they're on PPIs the rest of their life. Contrast that to somebody who has a family history of Barrett's and or esophageal adenocarcinoma. And we look down and they've got short segment Barrett's, but it's non-dysplastic. That's a different person. And what we know about that is if you have Barrett's and you have a positive family history, that's one of the strongest risk factors for progression. So that person I am going to worry about. And in fact, I do ablation on very few people with non-dysplastic Barrett's. I just told you how we shouldn't be ablating them because the risks aren't worth the benefits. That's one of the few people that I will offer ablation for because their risk of progression, what the data says, is that their risk of progression is quite high based on their family history. So that is somebody that you should take special note of. And if you get this history of Barrett's or cancer out of your patients and they have Barrett's esophagus, that's somebody you need to worry about.
Okay, thanks for that. I think we have time for maybe 1 or 2 more questions. How significant of a factor will non-endoscopic Barrett screening play in reducing the increased incidence of esophageal adenocarcinoma?
Yeah, great question. I think a lot of it depends on how widely we as champions for screening can spread this. You know, when you think about, my wife's a PCP, and the thing she says to me every day is, we need an easy button. People just keep adding stuff that we need to do in our 20-minute evaluation of these patients. Don't give me another screening test that I have to think about. Make it easy for me. So if we're good at this, if we do things like, if we're clever, if we use the electronic medical record and say, okay, we're going to find all the patients in our practice that are taking PPIs. As they come in, we're going to create a pop-up that happens in Epic or whatever EHR you use that says, have you considered screening this patient? They make a single click that says this patient needs screening, and we've set up in their PCP office a non-endoscopic screening so that once a week, patients can get these done in the office. Maybe the PCP office makes a little money from it. It's never going to get wealthy off this, but if it becomes financially permissible for them to do this, if it's easy for them to do this, then you see this getting some traction. And maybe this works better than what we're doing now. I already showed you that 90% of the time, the people with heartburn don't even get endoscopy. So the bar's low. We're doing a crappy job. You know, if we can even make, you know, a third of patients that have chronic GERD undergo one of these tests, we're going to be way ahead of what we do now, because what we do now is pretty cruddy. So, and maybe this is pie in the sky, but in answer to the question is, I think these have the potential for the first time since I've been doing this in the 25 years I've been doing it, to actually make a dent in this and maybe make a difference. And I could imagine it's already happening in the UK. I could imagine it working in the US as well. But we need to champion it. It's not going to happen on its own. You know, people that are interested in GI health, both gastroenterologists, surgeons, generalists that are interested in this, really need to say to PCPs, have you thought about doing this? We need to make it easy.
Absolutely. It seems like a great option. I think we have time for one more quick question. Let me take a look. Have you personally implemented the Eastwood Track Recital Sponge in your office?
Yes. So we've done hundreds of both here at UNC. And we do them as part of studies here primarily because we're trying to figure out how well they'll work. But we're actually setting up our path labs to do them in standard clinical care too. So I'm hopeful that there's a time, you know, UNC is a big system with 13 hospitals, et cetera. I'm hoping that sometime in the next few years, wherever you touch our system, wherever you walk in, that you'll be able to get this as an option for you. And you know what? Ultimately, gastroenterologists are always concerned, well, is this going to somehow decrease our business? I see it as enlarging our business. I think it's going to open the top of the funnel. It's going to allow us to see the patients we really need to be seeing. So I think it's something that we should be embracing and not something that we should be worried that it's going to somehow decrease our endoscopy business, because I think it's actually going to augment it. Not only is it going to augment it, but you're going to be doing patients that you've got a high chance of finding something in and making a big difference.
Absolutely. Well, thank you. All right, I think we're right on time. We have a couple minutes left. So Tracy, I believe I'm going to turn it back over to you.
Thank you, Christina, and thank you, Dr. Shaheen, for such a great presentation. We'd like to remind everyone that immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open and we appreciate your feedback. Again, the CE Certificate of Completion, to attain your CE credits, please visit www.soxtexting.com/INIT and register at the site and complete your evaluation. We'd like to thank everyone for attending today's webinar. This concludes our webinar, and we wish everyone a pleasant rest of your day. Thank you.